more insights. But before we dive into what our program actually does and the way we handled it, I would like to talk with you about why outcomes. And I'm sure all of you know the major benefits why we should track outcomes, but I want to point out some practical aspects about it. And in Germany, we have the tendency, I think, to focus on our mistakes. We measure the mistakes, we measure complication rates, we measure mortality rates. And just one example here, like this is a very easy, understandable, nice to read quality report from an average hospital. It shows you complication rates again, mortality rates, and to me as a patient, if I read that, I'm not informed, I'm not in a position to make a better judgment whether or not I should seek treatment in that hospital. I don't know about my health, how it's going to be affected by visiting that hospital. Am I going to be able to run a marathon or go on a hike again? This is not telling me anything that I can easily understand, to be honest. And for the hospital, I'm sure they're convinced they provide a really high quality of care. But is this the way to show your high quality of care? I don't think so. And I think we're focusing again on the mistakes we make, and instead we should try to learn from our best cases. And what are best cases? Best cases are the ones where the outcome is best, where the quality of life of a patient increased the most. And if we start measuring those cases, we can start learning from them. This is exactly what not only we try to do, but there's a whole, we heard it before, organization now advancing that topic. I brought a slide for them. It's the ICHOM. We have one of the experts here in the panel today. It's a worldwide organization, a global network that defines standard sets. We just heard the question, will outcomes play a role in the common quality management? It does not seem to be at this point. They're only focusing on routine data, maybe in some future. And I would like to show today at a really practical example why this cannot wait. And for us in 2014, the question was, how can we do this? Is it feasible to measure outcomes? And for us, well, I always like to show this picture here. Like, we can send robots to the Mars, and sending out some follow-up emails shouldn't be that hard. So back in 2014, when we founded Heartbeat Medical, and we asked ourselves the question, how can we measure outcomes? How can we automate this process so every doctor is enabled to track his results? And we've divided the program, the entire thing, in two parts. On the one hand, it's the clinical side. Whenever you see a patient in the hospital as a doctor, you need to document certain parameters. If you're focusing on the outcomes, there might be some more parameters, or there's a new regulation telling you, oh, you have to measure this or take care of that. We developed a web-based software that has the dynamic forms for the doctor in any situation to document his part of the process. The standard sets from the ICHOM give you direct guidelines on what you should measure. We can implement them here. No free text, it's only the parameters you need at this very point. So we make sure over the process from seeing a patient first, treating him, and afterwards to collect the necessary parameters that we can reference later to the results. This is the standard part. The interesting part is now the patient. How can we integrate him? And we had the HIMSS study last year telling us that a doctor spends on average 4 hours a day with documentation. And in that environment, you cannot start asking doctors to document even more. It's simply not going to work. So we have to automate this process. And well, up till now, usually if you want to ask a patient about his status of health, you get something like this. Paper-based questionnaire. If the hospital is a little more advanced, they will scan this questionnaire later and then have it in an Excel spreadsheet. Otherwise, well, there are 5 students every week typing in the results. Some of them are smiling in the front here. Okay, so this is a well-known practice, obviously. What we tried is simply to digitalize this. Again, it's not rocket science, it's just basic web technologies, and having it on an iPad, like, that's a no-brainer. Asking patients the necessary questions, the scores that either the ICHOM had for us provided, or the hospital has some common questionnaires in place. By doing that, mounting those tablets in waiting areas, mounting them in wards, we enable doctors to get all the necessary information even before they see the patient for the first time. And now let's jump in our system. And this is just one example, a ski accident here, and there's a score, it's called IKDC, which is a score for the status of health regarding your knee. For knee replacements, this is a good score to assess the patient's health. At 36, it's between 0 and 100, or we have here the 41. It's not a good result, and the doctor immediately can see not only the overall score, but also the single results. So this reduces his 4 hours he spends every day on documentation, giving him some more time because he has the necessary information available. This part, again, easy. What about after the surgery, after the treatment? We need to follow up, and so far we have heard many times that, and I quote here, a good patient is a patient who doesn't come back. Something wrong with that sentence. It might be so bad, the results, it just picks another doctor, but we don't know. And there's a simple solution to set up an online portal, remind patients via email, and get his feedback. He can answer questions online from the comfort of his home. Instead of trying to send him a questionnaire, asking him to put it back in an envelope, send it back, and then the whole process of transferring it manually again comes up. So what we do is afterwards follow up with the patient. And by we, I mean our system that is being deployed at hospitals or in small clinics. So the communication, and that is very important to us, stays between the doctor and the patient. Now, as a result, here's one example of how patient-reported outcomes can be integrated in an electronic healthcare record. We see again that ski accident here. We see that before the surgery, this patient ranked at, we have here 36, and at 24, 2 orthopedic scores. And we see that here a surgery has been documented. And not only are there some additional parameters down there with the arthroskopische Operationsbericht, but we also, and this is the really important part, now we have to follow up in there. We see his results, and they have significantly improved. Now, this is a proof that undergoing surgery was the right decision. And this is what we're exactly trying to do, automate this process. Now, if a doctor can learn from one case, well, he probably can even learn more from all of his cases. And I would like to show you here now is a live demo of our system. It's an ongoing study. Let me just switch here real quick. And what you see here are 414 knee ACL replacements. So the ligament in your knee, if it ruptures, you can undergo treatment and ACL replacement. These are 400 anonymized data sets taken with Heartbeat 1. It's an ongoing study. And we see here different parameters from the average age distribution, surgery times, and down here, this is the interesting part, that IKDC again. We have that score. Before, that's pre, we have 6 weeks after surgery, and we have 6 months later. And it's rising, 55, 62, 70. Now this is the actual status of health of the patient. Now, if you undergo an ACL replacement, there's a common question, where should I take the transplant from? And there are 2 different ways. We see here, first of all, from the hamstrings, let me click on this, and now the data updates. We see surgery time on average 83 minutes, then 55, 63, and up to 71 is the score. Remember, it's between 0 and 100, 100 being the best. So patients are improving by undergoing that surgery. Now there's a second option you could choose, and there's a transplant you could take from the so-called patellar tendon. It's a surgery that takes longer, up to 25 minutes longer. That means a lot more costs, but it's supposed to be a better option for certain types of patients. Now if I click on this here, what I see is patients do not improve significantly better than on the other hand. It might be here, this is only 6 months. Maybe we will witness that after 2 years it's significantly better. But this is what we're trying to do here. Give all information available to the doctor so he can learn from his outcomes. Any parameter in this can be connected to the actual outcomes. Looking at age groups, we can always see how the outcomes are. And this is just for ACL replacements. We believe that if you start tracking outcomes in that way, doctors, hospitals can significantly improve the quality of care, and patients can profit from that, from a more transparent way. And we think, and we feel that this is the information that needs to be published. So I, as a patient, know whether or not I'll be able to run my marathon again or go on a hike. That's Heartbeat 1, and we're really excited to get your questions. Thank you very much.
So we have some time for